Good morning, everyone. I think it's 10 o'clock, so I will start with the talk today. Last week I started to tell you the anatomy of the heart, and this is the second lecture about this organ. The program for today is the blood supply of the heart. This is what I will focus on. I will talk about the arteries mainly. I very briefly just summarize the veins because they have much lower clinical significance. After this step, I will turn to the pacemaker and conductance system of the heart. And finally, very briefly, I will summarize the nerves. Let's start because there is a lot to discuss today. Again, the arteries first. I would like to tell you. If I go back to the last week for a moment when we discussed the surfaces of the heart, multiple times I came to this point that I mentioned that we have the coronary sulcus, and this coronary sulcus we have the coronary arteries, and there is two coronary arteries in the human heart which are responsible for the blood supply. On the right side, you have the right coronary artery, and on the left side, we have the left coronary artery. This is what I would like to talk about the coming couple of minutes. And this slide is also known from the last week, I think. When I remove the atria and we look at the heart from above, you will see the fibrous rings. And just above the aortic valve, there you see how the right coronary and the left coronary arteries arise. The right coronary artery comes from the very first part of the aorta, which is designated as the aortic sinus, just above the right semilunar valvula. The origin is found. That's an opening through which the right coronary artery rises. On the other side, on the left side, again in the aortic sinus, you find the origin of the left coronary artery, which has a much shorter trunk, which splits into two main branches very soon. But I will come back to this point. So the right coronary and the left coronary arise from the aortic sinus above the respective semilunar valvulae or cusps, and they will run in the coronary sulcus. So this slide is about the right coronary artery, and here I would like to summarize the branches of that. Once again, arises on the right side of the aorta and runs in the coronary sulcus down until it turns back to the posterior surface or diaphragmatic surface of the heart and continues in the coronary sulcus to run downwards. Now, the right coronary, as you can see, has a couple of branches. Out of those branches, I would like to point out the right marginal branch that accordingly runs next to the right margin of the heart. And also on the back side, you have the posterior interventricular branch. Now, these two branches I highlighted with red boxes. These are the branches of the right coronary artery, which ones you must know. The other smaller branches are also important. They do have clinical significance, but these two branches, even for just a barely passed exam, you have to know that's the absolute minimum. But if you want to get a better mark, you have to know the branch to the sinoatrial node. You have to know the atrial branches. They provide the blood supply for the right atrium. Also, you have a conus branch that feeds the conus arteriosus, the efflux area of the right ventricle. And on the back side, you have a tiny branch to the atrioventricular node, which is one center of the pacemaker and conductance system. I will come back to this later. And there is the right posterolateral branch also. So once again, the right coronary artery has these branches, but you must know at least the right marginal and the posterior interventricular branches in the exam. Others I would also recommend to study. So what does supply the right coronary artery is the next question. So again, it's an anterior view of the heart. Now, please focus on the green color. The green color represents the right coronary artery and its branches. And the same colors are used on the other side here. This is the posterior aspect of the heart, and there you can see again the right coronary with its branches. And in the middle, in this scheme, people cut the ventricles around this plane, and this refers to the cross section. And the green color represents the area which is supplied by the right coronary artery. But let's make a list, which we will ask you in the exam as well. So what does the right coronary artery supply? Obviously, it gives branches to the right atrium. And as you can see, the branches down there, the major part of the right ventricle belongs to the area of the right coronary artery. It's very logical. The right coronary feeds the right atrium and the right ventricle mainly. But considering that the anterior interventricular groove or sulcus has another branch of the left coronary artery, it will also a little bit contribute to the blood supply of the right ventricle. So except this small area, the right ventricle belongs to the area of the right coronary artery. And also the right coronary with its posterior interventricular branch that's on the back side, as you have seen earlier already. So this smaller portion of the interventricular septum is also supplied by the right coronary artery. Not the bigger part. The bigger part is fed by the left coronary, but the larger part receives the blood supply from the posterior interventricular branch of the right coronary artery. And also, I have to mention that since the posterior interventricular branch, as the name suggests, travels in the posterior interventricular sulcus, a little bit of the area, a little area of the left ventricle on the back side is also fed by the right coronary artery. And finally, as I mentioned, we have a branch to the sinoatrial node, and we have a branch to the atrioventricular node. These centers of the conductance system will be supplied by the right coronary artery as well. Okay, so if the question arises, what functions or what areas does the right coronary artery have or supply, you have to have this list in your mind, and this is what you have to answer. Okay, so that was the story of the right coronary artery. Now let's look at the other one. The left coronary, as I mentioned, arises on the left side above the left semilunar valvula of the aortic valve, and it runs just behind the pulmonary trunk and up a few centimeters course, splits into two stronger branches. These two stronger branches are those what you must know. There is one which turns back, and that's the circumflex branch, and the other one is more visible in such an anterior view, and that is called the anterior interventricular branch that goes down. So these two branches you must know, anterior interventricular and circumflex. Now, these arteries have also their own branches, which we recommend to study also. The left marginal branch is a quite variable blood vessel. It may arise from the bifurcation. In that case, we see that it has three branches at the same spot, but mostly it comes from the anterior interventricular branch. And from the circumflex branch that turns on the back side, we get some branches to the left ventricle, which we can call posterior left ventricular branches. The anterior view still has one or, in some cases, multiple so-called lateral or diagonal branches arising from the anterior interventricular. And also you have a branch to the atrium. Do you hear me now?
Yes.
I don't know what happened, but just the connection broke. Did you hear the atrial branch, what I told you?
You were talking about it and then it cut off.
Okay, okay. I will go on with it. Just I have to switch on the recording is running. Okay, all right. So I don't know why I was just discussing. Moment, please. Okay, so we were at the circumflex branch, and then this is the atrial branch, which travels to the left atrium, and it provides the blood supply of the left atrium. So once again, please focus on the left coronary artery, and please study the anterior interventricular and the circumflex branch. This is the minimal knowledge what we ask from you, and if you would like to get a better mark, we also would like to ask you some other branches, but they are already quite variable and it's not easy to find them on the heart. Therefore, the main branches we will ask you to show for sure. Okay, let's go back to this slide again, and now I would like to tell you the area which is fed by the left coronary artery. So now you have to focus at the red color, and the red artery here is the left with the anterior interventricular branch and with the circumflex branch on the back side. And again, the scheme shows you the red highlighted area that is supplied by the left coronary. Of course, the atrium is that which I can start with. It gets an atrial branch from the left coronary artery. And next to the anterior interventricular sulcus, you have, of course, an area of the right ventricle. So this narrow area here receives the blood supply from the left coronary artery. This is part of the right ventricle, but it gets some blood from the left coronary next to the anterior interventricular sulcus. But if I check the rest of the left ventricle, the major source of its blood supply is the left coronary artery. You have the posterior side also, but it does not go till the posterior interventricular sulcus because, as I mentioned earlier, the right coronary has a branch there, and therefore on the left side of the posterior interventricular sulcus, a smaller area of the left ventricle is supplied by the right coronary artery. So about that size of area which is supplied by left coronary in the right ventricle, on the other way around, is also supplied by the right coronary in the left ventricle. So it's a bit kind of shifted here. And also please note that the interventricular septum here, which is supplied by both coronaries, receives more blood from the left coronary, so it's a bigger about a two-third area of the anterior interventricular septum is fed by the left coronary artery. So again, if the question arises, tell me what does the left coronary artery supply, then this list is that what you have to say as an answer. Okay, so I know that some students like to have an overview in a table-like way. So what I did now is here a summary of the blood supply of the heart in a table. And the first column of the table will list the parts of the heart, and then the red and the green using the same color code like in the last couple of figures. I will highlight what does the left coronary artery add to the blood supply of that particular area and what does the right one do. If the area is black, that means that doesn't contribute at all. So the left atrium is fed by the left coronary artery with its atrial branches. The right atrium is fed by the right coronary artery from its atrial branches. Then the left ventricle has considerable blood supply from the left coronary artery. That is the main source. You have the anterior wall part, you have the lateral wall part, and you have the posterior wall part, which gets blood from the left coronary artery. The anterior wall is mainly fed by the anterior interventricular branch. The left marginal adds more to the lateral wall, and the posterior surface gets blood from the posterior ventricular branches of the circumflex branch. So this is how the main part of the left, this is how the left ventricular is mainly supplied by the left coronary artery. But the right coronary artery, by its posterolateral branch, contributes a bit to the blood supply of the posterior wall as well. If we move to the right ventricle now, look at the black color, the proportion changes. Now the left coronary artery does less. So the narrow area next to the anterior interventricular groove is supplied by the left coronary artery, but the right coronary does more. With the conus branches, right marginal branch does the anterior wall. The right marginal branch also does the lateral wall, and the posterior wall gets from the posterior interventricular branch. Then the interventricular, I have to say, sorry, this wants to be septum, not branch. I forgot to correct this. So you have the septal branches of the anterior interventricular branch that does the anterior superior 2/3 of the septum, and the rest 1/3 is approximately fed by the posterior interventricular branch. So these two coronaries will contribute together to the interventricular septum. And finally, the important centers of the conductance and pacemaker system, the sinoatrial node and the AV node, are fed by the corresponding branches of the right coronary artery. So if you like to study tables, this may help you. And also in future studies, if you study cardiology and heart surgery, they most of the times use this classification regarding the walls, which do not always mirror the anatomical borders, but for clinicians, pretty much useful. Okay, so this is nice, but this is not always true what I'm saying, because most of the cases this is balanced. So most of the times this is the situation, but only in about 70% of the people you have this anatomical situation, because in other people you have a little bit stronger left coronary artery. And in that case, you have the posterior interventricular branch that is typically a branch of the right coronary artery is very small. And instead, you have a quiet, strong branch here from the left coronary, which takes over an area. And therefore, in this case, the left coronary artery supplies the left ventricle completely, and also a considerable area of the right ventricle as well. In this case, of course, the left coronary artery has a greater significance. So if the left coronary gets blocked or sick or constricted or narrower, you have a bigger problem with the left ventricular function. This is a little bit more common than this situation if the right coronary artery is stronger. In this case, the right posterolateral branch is more developed than usually. Therefore, the right coronary will do more, and the right coronary will then feed a larger part of the left ventricle than typically. And in this case, if the patient has coronary disease on the right coronary, we have a serious trouble because the bigger part of the heart doesn't get enough blood. So we don't know from a particular person if we have the balanced situation, the common one, or one of these less common cases, but it will interfere, of course, with the outcome of the disease or with the prognosis. Therefore, we have to see it sometimes. We have to look after what's going on in the patient, and I will come back to this point, how we do that. Functional remarks here. This is more physiology, but I think it makes sense to study this because even in our exams, these questions may come up. So first of all, these arteries will carry the blood to the myocardium, to the muscle tissue. But if the muscle contracts at the moment, it is compressed. So the branches of the coronaries which enter the muscle will be compressed during the systolic phase of the heart. Therefore, the diastolic phase is that time during which the blood supply, the oxygen and nutrient supply comes to the muscle tissue. So between two contractions, during the diastolic phase, the arteries will carry the blood because the aorta has its elasticity in its wall, and the elastic fibers of the aorta between two contractions will let the blood enter the coronaries, and during this phase the myocardium can get the nutrition. The other thing is that if this blood supply is not normal, of course the myocardium will suffer on lack of oxygen or nutrition. And in many parts of the human body, in the limbs also, you have studied that blood vessels may be connected to each other. You may have collateral anastomotic connections between blood vessels. Unfortunately, in the human heart, this is not the case. So we do not have usually considerable anastomotic connections between the right and left coronary arteries or between other coronaries. In rare cases, if some diseases develop slowly, it might happen that considerable collateral circulation develops, but in a heart, usually we don't have such a thing. Therefore, if suddenly, acutely, the coronary artery gets blocked by something, almost always distal to the place of the obliteration, because of the lack of oxygen, the tissue dies, and the so-called acute coronary syndrome occurs, what people usually know as a heart attack. In that case, we lose muscle tissue, and rhythm problems may occur, which may be deadly in the clinical practice. So you will hear a lot about this in many subjects like heart surgery or cardiology. So as I mentioned, the blood supply of the heart is quite variable, and we don't know from a particular case how does it look like in that particular person. So if you would like to see how the blood vessels of the heart are working, and if they are not sick or if they are constricted, you may use a technique that is quite widely used. This is the so-called coronarography. We have other ways also to visualize the coronaries, like with computer tomography also. But if you want to do something, if you want to treat it, the coronarography is a useful method, because you can even use this method for therapy. So if you do such a kind of technique, you will see the blood vessels of the heart like on this image. And because the time is very short, if you do such an examination, people usually use the short terms for the names of the branches. So these abbreviations come from the English terminology. You may meet this RCA, LCA, LCX for these branches. And what I call the anterior interventricular branch is in the clinical practice more frequently the left anterior descending branch, called LAD or LAD. And then it's also called widowmaker, because most of the times, or not most of the times, but sometimes this artery is in the background of the heart attack and maybe fatal outcome there. And lateral or diagonal branches are abbreviated by DG. So this is many times seen in similar examinations. And I also took a video, what you can download, and here are the links. You can have a look on those in the YouTube, but I show you in a moment if I can do that. I hope it will work. So I share now this screen with you. Just a moment. I hope you can see. If I start the video recording here, before I started here, you have a catheter in the aorta, and you will see contrast agent that is injected into the coronaries, and now you see that the heart is beating, and you see how the contrast agent will then mark the branches of the coronary arteries in different views. You can observe this. This is branches of the coronary arteries, and you can see how the blood enters, and the contrast agent makes it visible. Okay, then I have another video, maybe here. Yeah, no, it's not that well visible. I have another video on a similar one. Here you can see that the right coronary artery is examined. This is here the hip joint with the hand of the radiologist who inserts the catheter into the artery, and there it is, the catheter. And you will see that they pump the contrast agent into the coronaries, and there you see that here is a narrow area. somehow the wall of the artery was constricted. It's very narrow, so it's dangerous that it gets blocked, and then after this the patient would suffer a heart attack. So they put a balloon into it and they will blow it up. You'll see now that the contrast agent blows up the balloon, and then after this, if they remove the balloon and they fill the vessel again, so this is what I mentioned, that you can treat the patient using this method by making the blood vessel wider, and you sometimes have to insert a metal grid that keeps the vessel open. This is the stent implantation, what people also sometimes do. So this is the coronarography I wanted to share with you. You can download this, or you can have a look on these files also at home. Here I have some videos. You can just download them. And the other story, what I wanted to talk about is also a clinical issue. So if this technique doesn't help, because the coronaries are really seriously constricted or already completely blocked even, you have to find another solution for the problem. And in this case, you may perform a bypass surgery, in which case you may remove the internal thoracic artery from the chest wall that runs inside the sternum, and then you may insert it into the pericardial cavity, and you may fix it to the coronaries distal to the constriction, and you may make a bridge over the constriction, and then you can revascularize, you can restore the blood supply of the myocardium. You may use the internal thoracic artery, or in many cases, surgeons remove the greater saphenous vein from the leg or from the lower limb in total, and they may use this vein as an artery, but in that case, they have to make a suture to the aorta, and they will distal to the constriction, fuse it with the constricted coronary artery, and they can therefore revascularize the heart. I also have a video on this. It's a very long one, so I don't want to show you the whole thing, but you will see that it's a very useful video. So if you have some time, you may have a look. The link is found in the in my talk. Here is the chest already open, and the surgeons are already preparing the pericardium. The sternum is cut now, and then they are going to the heart. And at the same time, another pair of surgeons is standing at the lower limb, and they are preparing the greater saphenous vein there. And they are removing the greater saphenous vein. You will see in a second that they insert an endoscope. Here it looks quite brutal that they enter the thigh area here, and here is the picture, and this is what the surgeon can see from the blood vessel. Here is the greater saphenous vein, and they are preparing it out, and they will remove it, and they will use it in the heart later. So this is what the surgeon does on the lower limb, and the other people are working on the thorax already. They are opening the chest. So I skip now some time. You can have a look if you have some time how it goes. But here you can see that the heart is already exposed. The chest is open. There it is still beating, and then the surgeons are preparing for the bypass surgery. During this time, people have to usually stop the heart, and when they stop the heart, they have to insert large catheters in order to put the patient's blood into a machine which replaces the function of the heart. During the surgeons are working on that, and also the lungs. So there is a heart lung machine which keeps the patient alive during this stage. So this is which are people preparing now. And then after a few time, the surgeons will then go on, and they will stop the heart. Here is the tube which removes the blood already. And you will see that they put ice into the chest cavity. Now the ice is coming, and they cool down the heart, and they stop it. They can work on it, and they can make the sutures on the coronary vessels, and cooling down the heart will protect it that it doesn't get damaged during this time when there is practically no circulation in the coronary vessels. And then after some time, they will also start the sutures. Here you can see that with a very fine needle, they are making the sutures on the coronary artery, and then they insert now the greater saphenous vein into the heart, and they will make the suture on the coronaries. This is the vein, and here is the coronary artery, and they are fusing. And right now, here is the vein which is to be fused with the artery, and they have to make it, of course, without leakage. So it's a quite tricky suture, but with practicing, one can learn this. Okay, and then later on, here you can see at this time. I hope it will work. Yeah, now you can see that this a little bit bloody and fatty structure here is the artery. This is removed from the chest wall. This is the greater the internal thoracic artery, and they are making here the suture with the anterior interventricular branch to bridge it, and then to revascularize the heart. Okay, and then if this is done, many times people use multiple vessels, and a bit later you can also see that there is the vein here. The artery is not visible now, and the heart already starts to move. And a bit later, if we come back, then you will see that the heart gets its pumping function back again. With some delay, you see that the heart is already very well beating. They will remove these tubes in a minute, and then now it's removed, and then they can restore the circulation, and now the heart beats again and takes back the function which was done by the machine temporarily. And you see that the revascularization works. Here is the arterious blood circulating in the vein already. Okay, so this is how the heart surgery, the coronary surgery works, and I wanted to show you this video. And you can have a look at home if you have more time. You can check it out. It's a little bit longer. Okay.
I have a question.
Yes.
Is there any reason why they use a vein instead of an artery for this bypass?
The vein is easy to get. The vein is not missing. But if you remove an artery, it's not so easy to find an artery that we don't need. Sometimes people may take the radial artery also, and that is occasionally also used. But people say that the veins, if they use it, they are always immediately well working. Sometimes the arteries suffer a kind of constriction or contraction at the time of the surgery, and it has to adapt for a little bit longer period of time to the new function, and they may require some time. So in acute cases, they prefer the veins. And it's also known that if we study these grafts later, the arteries stay longer open. So if you use an artery for a longer period of time, decades or many years, the artery is still open, but the veins may be blocked. So there is a long time advantage for the arteries, but in a shorter period of time, it's more useful to use the veins. It depends also on the surgical situation. It also depends on that if the patient has a nice greater saphenous vein, because if the patient has varicosity on the leg and the greater saphenous vein is already enlarged, sometimes they just can't use it. Okay, so it depends on the case also. So let's go on, because the time is really rapidly flying. So this is what I wanted to tell you about the arteries. And very briefly, I run through the veins. I just list them practically. You will have a look on those in the dissecting room. We have anteriorly the great cardiac vein that runs next to the anterior interventricular branch of the left coronary. We have in the coronary small cardiac vein. And if we turn the heart around, you will see that the great cardiac vein and the small cardiac veins come. And on the posterior side, you have also a middle cardiac vein. And all these veins unite, and they form the coronary sinus, which is the main heart vein. There is a tiny vessel here. I indicated the name, the oblique vein of the left atrium. This does not have a great clinical significance, but its embryological background is very interesting. You will get a lecture about the veins development in the series of embryology lectures of histology embryology 2, and they will come back to this point. My colleagues will mention this vein. Marshall's veins is it also called sometimes. So finally, the coronary sinus drains into the right atrium. And this I showed you last time also. The right atrium is open now. And there you can see that the opening of the coronary sinus is here. It's narrowed by a tiny valve-like structure. It's the Tabesian valve. Valve of the coronary sinus is it also called. It's just a double layer of the endocardium. Okay. This is the main vein of the heart, but occasionally one can find really tiny veins which directly drain into the cavities of the heart. This was the coronary sinus opening, but additionally to that, we have so-called anterior cardiac veins which drain the blood from the anterior side of the heart, mainly the atrium, but some parts of the right ventricle also. And this is not very surprising since in the right atrium we have anyways venous blood. But now the surprise comes. Everywhere in the heart, if we study very carefully, there are very tiny veins which drain straight into the cavities of the heart. And considering that the left ventricle and the left atrium has oxygenated blood inside, that means that some venous blood is always mixed into the arterious blood in the right, in the left ventricle and in the left atrium, and therefore there is some kind of shunt circulation here, and that is why the oxygen saturation of the blood is usually not 100% because few amount of blood is mixed, venous blood is mixed into the arterious blood in the heart. That's related to the cardiac venous drainage. Similar veins we have in the pulmonary veins also, in the bronchial and the pulmonary veins anastomose with each other in the lungs. And these two places we have where the arterious blood may be mixed with the venous blood in the human body, in normal cases also. But it's just a few percent, so it is does not have a great significance in the clinical practice until it's less than a few percent. Okay, and now in the next part of the lecture, I will talk about the pacemaker and conductance system. This is usually known by students very well because earlier studies in biology usually discuss this issue. What I would like to point out that this is not nervous tissue. This is modified cardiac muscle tissue and not nervous tissue. Somehow people believe that it would be nervous tissue because it's many times indicated in yellow color in atlases, but don't think so. This is modified cardiac muscle tissue with specific ion channels, which will be responsible for their pacemaker function. There's a sodium leakage in the cell membrane, and the membrane depolarizes after a certain period of time. The function of this system can be studied by the electrocardiography, ECG. This we don't teach, and we don't have to study this for our exams, but in physiology and pathophysiology, you will hear a lot about this. And the system may be damaged. In cardiology, you will learn a lot about the medications which may help in these situations. The main center of the system is the sinoatrial or SA node or Kate flux node, which is located in the terminal crest in front of the superior vena cava. And this is the center which gives the heart rate. And if we are resting, 72 contractions in a minute on average will take place. From here, the whole heart is controlled. First, we have bundles which carry this signal to the other centers, and then it will be spread everywhere in the heart. The sinoatrial node has its own ability to generate the contraction. So there is no need for higher order control on this. Of course, we can modify the heart rate, but we don't have to control this all the time. Therefore, you can take out the heart, you can put it into another person. If you do heart transplantation, the heart will also continue to work if the sinoatrial node is well working. From here, as I mentioned, bundles will carry, internodal bundles will carry the signal towards the other centers. There is 3 bundles in the right atrium, most of the times defined, the Bachmann, the Wenkebach, and the Torel bundles. They have also anterior, middle, and posterior internodal bundle names. And there is an extra one which goes to the left atrium. The next center, what I would like to point out is the atrioventricular node, also called AV node. Aschoff-Tavares node is it also called. This is located in the Koch's triangle that is situated next to the opening of the coronary sinus above the tricuspid valve and the semilunar, the valve of the inferior vena cava. And this node is able to generate a frequency of 50 per minute. So if the SA node is sick, the AV node may take over its function, but it is not able to keep the normal heart rate. Its position is in the Koch's triangle. I mentioned this last week, but just to have a look, this is the inferior vena cava, this is the valve of the inferior vena cava, and here is the coronary sinus, and there is the tricuspid valves part here, and this is the Koch's triangle, and there is it. Next to it, you have a red marked area that is not an anatomical name here, but it has a great clinical significance. That is why I mentioned the name. It's called cavo-tricuspid isthmus. Here is the place where, we don't know why, but here is the place where sometimes the cardiac muscle tissue has some malformations or some problems which lead to rhythm problems, and the cardiologists, heart surgeons may do catheter ablation here, which means that they burn away these abnormal muscle tissues in order to reduce the problems with the patient's rhythm or heart rate. You will learn about this in your later studies. It's in the cavo-tricuspid isthmus next to the Koch's triangle. Then from the AV node, we go on with the His bundle, also called atrioventricular bundle. And finally, we will enter the interventricular septum, first the membranous part, and then it splits into the 2 branches, but that occurs already in the muscular part. From here, we get the electric activity into the ventricular wall. And in the ventricular wall, we have 2 branches of the His bundle. As I mentioned, you have the right branch, or crus dextrum in Latin, and you have the left branch, or crus sinistrum. Tavarian branches are also called sometimes. The right one travels in the septomarginal trabecula. The left one has 2 branches. You may define an anterior and the posterior fascicle, which may get damaged separately, and you can see this in the electrocardiography. You will learn about this, how to figure that out. Okay, and then at the very end of the system, you have the Purkinje fibers. Please note, still the muscle tissue, which will provide the control for the rest of the muscle tissue. This is a modified muscle tissue. It can do some very slow ventricular escape rhythm, but that does not satisfy the requirements. So we have to do something that the patient can live with this. And we'll come back to this point, how we do that. So this is just a picture. You don't have to study that for the exam, but you see that the contraction on the signal spreading in the heart on this system will be pictured, or will be studied by the electrocardiography, and these curves you will study during your later studies in physiology and pathophysiology. Here is an example of some rhythm problems. This is a normal sinus rhythm, and here is the AV node destroyed or doesn't work, and you see that the atrial and the ventricular contractions don't have anything to do with each other. It's just an example, but you will come back to this in your future studies. It's not our field. And what I mentioned, that if the pacemaker conductance system doesn't work properly, we have to implant a pacemaker that will be a catheter going into the heart, and this can artificially maintain the normal heart rhythm. And you will study this also in heart surgery and cardiology, how these pacemakers can be set. Okay, and I'm sorry about this technical issue. I still have one point to discuss, and therefore I will speak maybe a few minutes longer. So the nerves I have to briefly summarize, and then I let you go. So the innervation of the heart is depending on one hand on sympathetic and on the other hand on parasympathetic nerves. The autonomic nervous system does control the heart rate, and the SA node and the AV node receive parasympathetic innervation by the vagus nerve, by its cardiac branches. And these nerves will reduce the heart rate because the parasympathetic fibers will excrete cholinergic. They are cholinergic. They throw out acetylcholine, and that inhibits the functions. On the other hand, the sympathetic trunk will give sympathetic fibers to these centers, and they will accelerate the heart rate. They throw out norepinephrine, and that will increase the function of these centers. And they will arise from the superior and middle cervical ganglia. They are on the neck. And in the chest, there is the stellate ganglion. I will show you in my next slide where it is. And in some upper thoracic ganglia, we also have these neurons which control the heart rate. So these nerve fibers will approach the heart already mixed, and this is the so-called cardiac plexus. And this will innervate the heart, AV node and SA node, but other muscle tissues do not receive innervation in the heart. Just the SA and the AV node is controlled. This is the image or the slide what I mentioned. So this is the vagus nerve going down. This you will practice in the dissecting room how to identify, and there are the cardiac branches which approach the heart. And also here next to the spine you have the ganglia, the stellate, and also the upper thoracic ganglia, and they will also provide the sympathetic fibers, and they will increase the heart rate. And finally, we have a sensory innervation for the heart also. That comes mainly from the phrenic nerve that is down running here between the pericardium and the pleura. And the phrenic nerve has sensory branches that comes from the fourth spinal nerve. So it goes up on the neck, and there it enters the spinal cord. And therefore, cardiac pain is referred to a body part that is innervated by the fourth spinal nerve. And I will come back to this point with my last slide. But before that, I mentioned that some sensory fibers will join the sympathetic trunk also. And we also have in the vagus nerve sensory fibers, but this does not get the conscious level of processing. So the vagus nerve feels the heart function, tension of the wall, and how much blood we have in the heart at the moment, but this is something that is not perceived voluntarily or consciously, finally. Okay, so these are the sensory functions. And the last point today is that what I mentioned already, that the heart has an innervation that comes from the fourth cervical segment through the phrenic. And because of this reason, if somebody has cardiac problems, the heart pain is referred to the surface of the body, because the body's surface is innervated by the same spinal nerves from which this phrenic nerve also arises. And typically in a heart problem, the patient's pain may be referred to this red highlighted area from the jaw down to the fingers, to the index and the ring and the little finger area. And typically the maximum of the pain is in the chest. So if your patient has such a symptom, to think about the for instance, the blood supply problems of the heart, and that's a kind of referred pain. Okay, so this is what I wanted to summarize today. Thank you for your attention, and sorry about the technical problem in the meantime. I hope you still can use the lecture. Thank you for your attention.